have seen to do with drug-induced liver injury, either coming from the ART, which we are taking, or it might be from the anti-TB medication or the septrin or other hepatotoxic drugs. So this is something that we should be aware of. Patients who are taking ART tend to have increased risk of liver disease coming from drug-induced liver injury, and usually associated with very poor outcomes because of the late diagnosis and the poor management. We also see a lot of chronic hepatitis infections. This is also very common, liver cirrhosis or fibrosis and alcoholic liver disease. So these conditions are some of the most common presentations of liver disease in the setting of HIV that we should be aware of. Most may present with presentations of liver failure. So we should be, the clinician should be aware that they should look out for some of these common causes in order to be able to diagnose and manage the patient properly. When it comes to neurologic emergencies, CNS infections, yes, are the most dominant cause, and especially for TB and cryptococcocal meningitis that has already been discussed. But there are other emergencies which you are likely to encounter. Seizure disorders like status epilepticus, you can encounter them. Neurocognitive impairment, mood disorders, or suicide, some CNS malignancies. We should be aware that they can present with neurologic emergencies, commonly with symptoms of either altered mental state, seizures, or loss of consciousness. So it's not just infections that you should worry about. There are other non-infectious causes that can result in presentation in neurologic emergencies in the setting of HIV. Kidneys, yes, also there's data to show the increased risk of kidney failure, acute kidney failure associated with HIV, and some data also shows there's increased progression to chronic kidney disease. So this is something to be of great concern. We know most of the kidney disease, chronic kidney disease, is associated with some of the NCDs such as diabetes and hypertension, but also there's some data to show that HIV and increasing age might be also key drivers to presentation of chronic kidney disease, especially in those who are of advanced ages. So in the realm of emergency care, you're going to come across this abbreviation, the 6 H's and 5 T's. We like to teach them a lot in emergency medicine setting, but we'd like the audience to remember that all the medical or surgical emergencies that an HIV patient might present with can be HIV or cannot be HIV. They most likely zero down to these 11 causes of cardiac arrest, and we hope that at the end of this session, colleagues will be able to remember them and keep screening and managing them adequately, because they are usually the leading cause of cardiac arrest and resulting in hospital mortality. So conditions such as hypoxemia, hypoglycemia, hypotension, hypothermia, acidosis, potassium disorders, toxins which come from different etiologies, tension pneumothorax, pulmonary embolism, myocardial infarction, and tamponade. All these, I like to call them physiological emergencies, are going to result, the end result is usually a cardiac arrest and death of the patient. There are so many conditions which we shall interface, so many clinical diagnoses that we as clinicians are going to interface with, but the underlying physiologic pathology or disorder will usually zero down on these 11 emergencies. So it's very keen for us to be aware of them. We have, I've just listed some of the common, on the column in the right, some of the common conditions associated with them, just for example, but you can see some of them are, you've already touched on them, like the infections, dehydration, vomiting, organ failure, DVT, and so on and so forth. All these conditions will result in physiologic emergencies and cause elevated risk of mortality, or the patient suffering an unfortunate outcome of mortality. So the question I posed for you, maybe, I don't know if our colleagues would want to respond. Of these 11 emergencies, it's just a question for you to self-reflect. But which of these 11 do you think are the most poorly managed emergencies in your setting? Maybe I would just allow 1, 2, or 3 volunteers, what they think are the most poorly managed emergencies.
Yeah, you can just go ahead and put your hand up if you are volunteering to answer that question.
Yeah, we just need like 1 or 2 persons, because most likely they'll be close to the answer. I see Nuruddin.
Hypertension. Yeah, hypertension.
Yes, hypertension. And also see some responses on the chat: pulmonary embolism, acidosis, electrolyte imbalance, tamponade. Yes, all these could be potentially correct, because all of them ultimately will result in cardiac arrest. But from our experience of working within the ED, I don't know if this is only unique to Kiruddu, but I think it's probably happens in every other health facility. We see the most common poorly managed of those emergencies tends to be hypotension. That is very low blood pressure. And I always ask, for example, ask the interns who are rotating with us why they think this is a problem. Why do they think hypertension is poorly managed? And comes down to basically 3 things: inadequate resuscitation, so you don't give enough fluids or treatments with vasopressors; inadequate monitoring, so you write the treatments down, but you have no plan to monitor the progress of the BP measurements; and we don't get down to the root cause of the hypertension. So you're just giving fluids, but with no idea of what is causing the hypertension. So we suggest that we should be more aggressive with our resuscitation. Do not take hypertension for granted. It's usually, I don't know, might be ignored for most of the time. Oh, it is slow to correct, and with infrequent monitoring, and usually that results in very poor outcomes. The second condition, I think, which is poorly managed in a setting of a hospital, would be potassium disorders. And these are because potassium tends to cause a lot of instability to the electric potential of the myocardium and will result in arrhythmias, which will ultimately result in cardiac arrest. I see the problem here tends to be in delays with being able to diagnose the potassium disorder. So we will say we are waiting for the chemistry results, and many times this is a very common feature in many hospitals. The chemistry results take a long time to come back, but the potassium disorder will not wait for you to get your RFTs. So here we propose we should utilize some rapid tests like doing an ECG to identify some of these potassium disorders. And there are very many limitations to that. Clinicians not being able to, either they don't have the equipment or maybe the skills to interpret. So we feel if we could improve a lot of training on interpreting ECG, improve availability of the monitors, and improve turnaround time of some of these test results, then maybe we shall be able to better manage the potassium disorders, which usually result in very poor outcomes. And you don't see it only in the setting of HIV. Very many other conditions that cause potassium disorders, whether it's kidney failure, treatment toxicity like amphotericin, and so on and so forth. And the last one, which I think deserves a lot of attention, is myocardial infarction. This, I think, primarily might be due to misdiagnosis. We as clinicians, we tend to look for the wrong symptoms. We're looking for a sharp retrosternal chest pain, but forgetting the pain of myocardial infarction is usually never sharp. It's has a very dull characteristic. So visceral type of pain, that's what I'm trying to say, compared to somatic. So if we go looking for the wrong type of pain, we shall misdiagnose. Often it's misdiagnosed with ulcers and gastroenteritis and so many other conditions. And many times we're not able to recognize either the typical or the atypical or the silent presentation. So clinicians, yes, have to improve our clinical acumen and investigations to be able to potentially manage these common emergencies that will ultimately result in poor outcomes of the patient. So in conclusion, I conclude by telling you we see a lot of deaths among hospitalized HIV patients, and we appreciate HIV disease affects multiple organ systems because it's an infection. Infections can affect any organ system, either due to a co-infection or due to another type of complication. All these organ system failures result in physiologic derangements, those are your 6Hs and 5Ts, and the end result is a cardiac arrest, or that is the end stage mortality. The approach I would suggest for the listeners to take home, number one, let us do a lot of triage and make effort to identify and correct the underlying physiologic emergencies. Most of them are not very hard to identify. If we do vital measurements for each patient, we can be able to identify majority of these physiologic emergencies because the vital signs tell us a lot about what physiologic derangements is ongoing within the patient's body. Secondly, make effort to identify and treat the cause. So these physiologic emergencies don't occur by themselves. Something else has caused them, so we must make effort to identify the cause, treat them, optimizing organ support care, and finally monitoring clinical progress by checking our vital signs. So I'm hoping with this, I guess that was the last slide. I hope the message would be taken home by whoever is listening in, that yes, whereas you see these emergencies within the setting of HIV, you also see that many of these emergencies can occur even in non-HIV patients. The bottom line is they're still emergencies, and we have to do a lot of, we have to improve our clinical practice to respond and treat these emergencies. Over to you, Chair. Thank you.
Thank you so much, Dr. Darius Owachi, for that an elaborate presentation. And I'm going to give chance to 2 questions strictly because of time. 2 questions towards Dr. Owachi's presentation. Anything that you'd want him to clarify or elaborate more on, I will give you opportunity. But if you can just raise your hand. And if there are no direct questions, I'm going to maybe ask Dr. Ronald Kasigaziomeri, Ellen, if they have cited any particular question that they think the audience would need to hear. And also Dr. What you would want to needs to respond to, I will give them opportunity as well.
There's a couple of questions. One of our colleagues asked what you do in the case of heart-related, like drug-induced liver injury. Do you have any particular approach to that? And also in the case of cryptococcal meningitis, if a provider doesn't have amphotericin B available, do you have an alternative to suggest?
Thank you. Dr. Okay. Ronald, is there anything from your side before Dr. Owachi can respond to them at a go?
No, not from my side.
All right. Okay, Dr. Darius Owachi, you can go ahead and answer those questions, those 2 questions.
So the first question was about cardiac, but I didn't quite get it well.
The question about how do you approach highly active antiretroviral treatment related liver injury, drug-induced liver injury.
Oh, it was liver injury, yes. So liver injury is a very common complication of drug-induced liver injury is a very common complication of some of the common treatments that we use. I think the prevalence is somewhere between 20 to 30%. And unfortunately, the mortality is usually very poor because one, we as clinicians are not keen to look for the liver injury. And two, by the time the patients present, it's usually when the liver is in overt liver failure and the outcomes are very poor. So the approach I would suggest is number one, we should be aware of, for each medication that we prescribe, we should always check the side effects and check whether there's a potential for organ injury. Usually they are listed in either the drug, the drug sheet that comes with the drug, or you can ask your pharmacist. But you should improve our awareness that the drug can potentially cause organ injury. And if there's the potential to cause organ injury, there should be a plan to monitor for organ injury within somewhere around the time the treatment was started. For example, if it is the case of anti-TBs, there's a recommendation before starting anti-TBs, they should at least have their liver functions checked. And ideally, even after starting anti-TBs, they should have routine checking for their liver function tests. By doing this practice, you can be able to, number one, identify the DILI at its early onset, and then number two, intervene in time, not waiting for the injury to become worse when the patient presenting with liver failure and then becomes extremely complicated to manage. So approach I would suggest is let us adopt a proactive approach to screening for organ injuries by, number one, studying the drugs that we are giving, what side effects they have, and then having a plan to monitor them. The second question, I think, was about when you don't have amphotericin B. I think the treatment guidelines have options. You can use the combinations, but a very high dose of fluconazole with flucytosine. And of course, there's also concern for liver toxicity because using really high doses, I think up to, I forget the dosage, it's really high. And so about a 2-week period. So we should be cognizant of the fact that the medications we give have the potential to treat the condition, but they also have the potential to add more injury in terms of organ failure. So let us be aware of that and seek help whenever we need it.
Thank you so much, Dr. Thank you so much, Dr. Darius, for those answers. I think for the sake of time, we are going to go straight to our nursing care. It's been quite a privilege having you, Dr. Darius, in this session, and I encourage the audience, if there are still more questions, you can post them in the chat, and I'm very sure that you'll be happy to respond to them. I'm going to go ahead and welcome Diana to take us through the nursing care, which is one of the very important aspect of care for these patients while they're in the hospital. Diana, over to you.
Thank you, Chair. Thank you, Chair. I'm Diana Nanyanzi, and I'm a nursing officer, and I'm here to take you through the nursing care and counseling of a newly diagnosed patient at emergency department. But before that, I'll first take you through our previous statistics in January, just to show you our current status of the inpatient HIV care at Kiruddu. We're able to enroll about 100 HIV inpatients, greatest percentage being males. And we were able to identify about 20% newly diagnosed HIV patients. With this trend of test and treat, we are aware we are supposed to test and then start treatment on the same day. But like you observe on the statistics, we're only able to start 5 out of the 20 patients. We also had 24% of our patients being ad defaulters, and we successfully reinitiated 9 out of these. And some of the reasons why we were unable to initiate ART were transfer out to other peripheral units, to other national referral hospitals like Mulago for specialized care, start on anti-TB, start on fluconazole prophylaxis, and then ART deferred by attending physician because these patients were still under diagnostic workup, and then early discharges, and then we lost 3. And in the outcomes, we observe our mortality was at 29% for the whole month, and about 34%, that's 10 out of the 29, had either defaulted on ART or they were newly diagnosed with HIV. And the highest predictors of mortality amongst these patients of advanced HIV disease, if we to look at the opportunistic infections, tuberculosis took lead at 31%, followed by oral and esophageal candidiasis at 14%, cryptococcocal meningitis at 3%. And if we to look at the other side of comorbidities, we still observe kidney disease at 28%, malaria at 17%, and severe acute malnutrition amongst these patients. We also observe predictors of mortality by patient challenges, where the greatest percentage of our patients, that's around 93%, presenting with poor performance scores in critical state, where they're unable to be supported while walking, or they are very sick with reduced levels of consciousness, amongst other factors, financial constraints, delayed diagnosis, amongst others. Why did I bring this on board? This is for us to appreciate the advantage of proper and prioritized nursing care and counseling, because if a patient is not well counseled, or if they're not provided with the right full information, there are the same patients who go in the community default, and then they come in critical state, and then they shoot up the hospital mortality. So this is just to make us aware that these 2 aspects are very important in management of a newly diagnosed HIV disease. So nursing care is aimed at coping with health problems. We very well know, like in the previous presentations, these patients present with a cocktail of so many problems. Some of them just don't present with only HIV, but they present along with other complications or other comorbidities. So we want to help these patients get the care to help them cope up with the health problems, then monitor and manage opportunistic infections and comorbidities, and then provide comprehensive HIV care and support to help these patients achieve the best possible quality of care or to live positively. And then one other thing to note, that at emergency, prompt medical attention is needed if a patient presents in an emergency state. And for HIV counseling, this is a confidential dialogue between a health care provider and a client. And then in this case, this counselor or healthcare provider should be able to provide adequate information through demonstrations and whatever is available, for example, job aids and everything. So you have to ensure this patient has received the rightful information so that they're able to understand their disease. And this enables a client make informed decisions, and it enhances understanding of HIV disease. It aims at improving communication and coping skills. For sure, being newly diagnosed with a chronic illness is not easy. So we should ensure we support this patient through the situation. It also helps to strengthen it helps to strengthen self-esteem, and it promotes optimal mental health, and it enhances adherence to medication. So nursing care. Here we admit patients. We carry out rapid physical assessment, and you can do an initial physical assessment following the ABCDE approach, where you assess for airway patency. You also look at, you assess whether this patient is breathing, the rhythm of breathing, and then you also assess for saturation, where you look at the skin color, you look at the capillary fill, you also check for disability, where you focus on assessing for levels of consciousness, where you can assess whether the patient is alert, whether they can respond to pain or words, or they're unresponsive. And then that helps you to act. So this will draw you to triaging of these patients. In patient triage here, you look at a patient's whatever findings or whatever symptoms this patient presents with is what determines their urgency of care. Most patients with advanced HIV disease present in critical states with reduced levels of consciousness. Some are conscious but unable to walk. Some have altered vital observations, they're tachypneic, they have tachycardia, their blood temperatures are above 39 degrees Celsius. They have bilateral edema, so they present with a lot of things that point out to the advanced HIV disease. So you triage these patients and you act immediately depending on the need of this patient. For example, for patients with immediate action, we triage them in the red zone. And then for those that can be observed, go to the yellow, and those that can be kept in the queue can wait in the green waiting area. This also allows us to prioritize care, whereby, for example, if a patient presented with difficulty in breathing, and then some other one just is presenting in with cough, we attend to the one with difficulty in breathing first, before we attend to the other person. So the next step is to confirm HIV diagnosis. Once a patient is newly diagnosed, we go ahead and do a validation test to confirm that they're really diagnosed with HIV, and you provide information, post-diagnosis and post-disclosure with confidentiality. So if this patient is having reduced levels of consciousness and they have an attending caretaker, you can discuss with this caretaker the management of this patient. But if the patient is alert and conscious and they can make decisions, you still engage this patient and then ensure you keep privacy and confidentiality. So you identify significant medical history, especially if they have any history of ART, or if it's their first time to be diagnosed, because some patients come to hospital when they're testing the 7th time, the 2nd time, but when they are still ART naive. So you find out that history and then allergies, especially to sulfurs, because we plan to start this patient on cotrimoxazole prophylaxis. And then you screen for opportunistic infections to rule out advanced HIV disease, where you can do a bedside urine lung test or a serum CRAG as a bedside. And then you send for us, before you send for a CD4, depending on how the patient is presenting. Because when we're ruling out advanced HIV disease, that those danger signs we look at, and we really don't even need to wait for a CD4, but we screen for TB and cryptococcal meningitis. And as we observed previously in our slide, we realized that there are
not supposed to be ours.
strong predictors of mortality. So we worry much about this patient. You carry out a nutrition assessment for a patient that presents with a mid-upper arm circumference of less than 19.0. You worrying, and then you cancel them on nutrition. And then you can also enroll them for ready-to-use therapeutic fits, depending on how they are presenting. Of course, you rule out things like vomiting or GI intolerance. And then you follow up on laboratory investigations that can come up, like CD4, gene experts, in case this patient can give us sputum. Because as we know, we do the LAM, we also have to do the gene expert to rule out rifampicin sensitivity. And then we also look at the nursing care plan. As previously discussed by the former presenters, they were giving us clinical diagnosis for these patients, but we as nurses also have nursing diagnosis where we form our nursing care plan of these patients, depending on how they present. For example, a person who has an altered mental status can have a nursing diagnosis of ineffective cerebral tissue perfusion related to reduced cerebral blood flow, as evidenced by low levels of consciousness or low GCS. And then you as a nurse, you act according to your diagnosis, according to your assessment. You come up with a plan. And for this patient who presents in that state, you can collaborate with the interdisciplinary team to ensure you determine the appropriate care. And in this case, you can be joined by the ICU team amongst other team members. Someone who has difficulty in breathing can have a nursing diagnosis of impaired gaseous exchange related to respiratory infections, as evidenced by hypoxia, where someone presents with a low SpO2 or they have the difficulty in breathing. So for the nursing diagnosis, you act or you do these interventions or you provide the nursing care depending on what symptoms are presenting with these patients. And then for the interventions, like I discussed earlier on, it's based on the assessment done. For example, a patient who is immobile is at risk of impaired skin integrity related to them being immobile in bed. So this is a patient who would have to assist, working hand in hand with the caregiver. Because at times, due to staffing, you might not be able to do it well, but with assistance of the caregiver engaged, you can be able to give this support. And for patients like who need feeding, it's when you cancel on nutrition, you insert the NG tube in situ, and then you support the 2-hourly feeding. But all these interventions, like I said, it depend on what emergency state this patient is presenting in. So we also look at medication management and administration. And for medicine management, you have to explain to this patient or attendant how this patient is going to receive the care. For example, for prophylaxis, you provide the cotrimoxazole prophylaxis. And then you can also provide fluconazole prophylaxis if a patient has a positive serum CRAG and a negative CSF CRAG. And then you can also give TB preventing therapy, but all that depends on the state of this patient. Because there are some patients you get who are alert and fairly stable that can take up this. But for a very sick patient, you might really need to only do cotrimoxazole prophylaxis, and the AT will always wait. So for the adherence counseling, you assess for readiness of ART. And like we all observe that most of these patients with advanced HIV disease or the newly diagnosed HIV disease patients, we have to investigate them and rule out opportunistic infections because we also don't want them to develop iris at the end of the day. because we also have cases of some people who have been on, some patients who have been on ART for 1 month or 2 weeks, and then they come in worse than how they presented. Then you also do ongoing physical assessments, and this helps you to determine the early warning signs, where you keep monitoring your vitals, you keep assessing levels of consciousness for this patient, and it helps you act. In case this patient is deteriorating, you report to the attending doctor and you share your findings. Then you also do psychological assessment, where you look for the social support from the family, friends, who is attending to this patient. We've had cases of so many patients being admitted with no attendant, and it really hinders a lot of care for these patients. And for such patients, you can link them to the social worker. You also need to document your findings and share with the attending doctor. And then you continuously give patient education. So coping with HIV positive status, being newly diagnosed with any chronic illness, especially the HIV disease, we know that is highly stigmatized in the community. Someone's mental status needs to be supported through their attendant or through you, the health worker. So you should take time to really explain to these patients. So some of the things we worry about is self-stigma. Some patients think every time you mention about HIV, you mean them, even if you're on ward and they are, for example, in the infectious disease ward, the greatest percentage of our patients have HIV, but even if someone is health educating about HIV, they might think you're actually talking about only them. And at times it affects their adherence, disclosure, at least to one person that they think they can open up to, depression, this from the steps of breaking bad news. Some patients really get depressed and find it hard to move on and understand the situation. So as you're talking to them, you have to put it into consideration, self-esteem and self-criticism, fear of violence, among others, and then fear of death, especially if these people come in with so many diseases. For example, a patient presenting in with tuberculosis, with CCM, among other illnesses. So while we are providing psychosocial counseling and this framework, we follow up the behavioral change model to help us develop a self-management plan for these patients. So when these patients stabilize and they are worked on, because in emergency, most of them spend 0 to 48 hours. And if they are stable, they're transferred to other wards. And we continue providing information about the disease as we also carry on with other diagnostic workups. So you assess the patient's beliefs, behavior, and knowledge. At times we face challenges in this, where some people are having religious challenges, where someone believes they can heal through herbal medicine, through believing their pastors, amongst others. And then you also assess the knowledge of this patient. How much do they know? And then you provide, you advise by providing specific information about the health risks and benefits of change. And then you agree with collaboratively setting goals with this patient, but you base this depending on someone's interest or confidence. For example, someone can tell you, there is a week ago, we newly diagnosed an HIV positive patient who was a traditional healer, and it was really tricky. It was a little tricky for us to convince him that it was really HIV for him. As he said, the gods cannot, it's not acceptable that the gods can actually allow him get the HIV. And it also happened that he had the urine lump positive grade 3. So at first it was so hard for him to really even start the anti-TBs, but with time and continuous talking to him, continuous therapy and support, he was able to take up his medicine. And we are still doing follow-up to see how we can support this person. So he also assists in a way of identifying personal barriers, for example, patients in disordered relationships and their strategies, and then problem-solving techniques, you can keep encouraging someone who still believes they can heal by encouraging them to continuously take the prescribed medication as they still believe they can be better. And then you also arrange where you specify plan for follow-up. For example, visits, phone calls, and patients who are under the advanced HIV disease program that are admitted in Kiruddu are followed up by via phone call at 2 weeks and at 4 weeks. And then they are also encouraged to come back for review through the advanced HIV disease clinic so that they are supported. And for those that are still willing to be in our art clinic, for example, those that don't come from far are retained, but those other ones are transferred out. So as we set up a personal action plan for this patient for self-management, we should be able to understand that you assess, you advise, agree, assist this patient and arrange any plans. For example, you can tell them we can call you every 2 weeks. We keep telling our TB patients that we shall always call you prior to your appointment date, just to motivate them. And then if our patient is stable and they're ready to start IRT, for example, like Dr. Isaac explained that for those with Cryptococcocal Meningitis, they take between 4 to 6 weeks. And then those with TB, it's after 2 weeks, according to the clinical guidelines. So you ensure you provided the accurate information. That's why I emphasize the validation test. You also provide information about care for the available facilities, either in your facility or catchment area, anywhere they feel comfortable with. You also describe the next care and treatment steps, that now that you've completed your 2 weeks course of treatment, we need to start ART and you need to continue with your other treatment. So you discuss the benefits of early treatment initiation, and then you also discuss the consequences or any challenges that can encounter in case someone delays in starting treatment. You identify and address any linkage barriers. Linkage is when you start this ART naive patient on ART. So you link them direct to the ART services and you ensure they've started their ART. So you involve the patients in decision-making regarding care and treatment. Some patients might not be conversant with or very comfortable with starting ART in that specified peripheral unit, and they wish to go somewhere else, probably because of distance or financial constraints, and then they ask for transfer out. So you can start the ART if the patient is eligible, and then you transfer them out. And you ensure you also follow up on whether they've reached wherever they wished to stay for continuity of care, so that these patients don't show up as ART defaulters, very sick with those other comorbidities or opportunistic infections that they didn't have previously. You ensure documentation, especially if you're referring this patient on the comprehensive referral forms. And then if this patient is starting ART in the same facility, for example, if this patient was discharged and then they were reviewed in 2 weeks and they're eligible for ART, you hand them over to the counselor or linkage facilitator who takes them through enrollment process. They open up a file, they start ART, and they get prescription counseling where they discuss about the time they need to start the ART, where they discuss any challenge, any likely challenges, and you ensure a follow-up. So for same-day linkage, it's really not possible for patients who present with advanced HIV disease. So you keep following up on them, either on ward or in their community, and you ensure that they start their ART. So the key highlights, as I conclude, triaging of patients is key because it helps us as nurses to prioritize the nursing care that is specified for a particular patient. Ensuring prioritization of nursing care and proper documentation with shared findings is also very important. As nurses, we shouldn't just take vitals. You see someone has very low BPs with a high respiratory rate, and then you document in the file and sit. you have to read the findings, interpret them, document them, and share with the attending doctor, and you act. Because management of these patients is with a team. You can't manage these patients alone. Then you ensure privacy and confidentiality of these patients because of the stigma that comes along with these, the judgments, the other people's perceptions. You only need to engage other family members when this patient is really able to, when this patient has consented. But like I said, I highlighted earlier on, if this patient comes in with reduced levels of consciousness, you engage that caretaker who comes with the patient and you see how to support this patient through. Then you screening for opportunistic infections is key. Rule out advanced HIV disease by doing that CD4, by doing the bedside screening for LAM and Cryptococcocal Meningitis, and then ensure assess for readiness of starting ART for these patients, because patients also have rights. Someone can just say, Mosawa, I'm not ready, but ensure you convince them or talk to them to the best way you feel, because you also want them to live positively and do other things. And then you provide adherence counseling and then ongoing counseling. Thank you, and back to you, Chair.
Thank you so much, Diana, for that comprehensive nursing care action plans for patients admitted with HIV, even those that are newly diagnosed, and now to go about their care. And like I said, HIV is a topic of interest in our area of practice, and particularly in our region. And when we begin to talk about HIV, we can talk until when the cows come back, like I said earlier. Yeah, I would like to appreciate everyone who has spared time to be part of today's ECHO. We have our post-session polls already on. You can be able to access them. Just go to the, should be the right corner of your screen, and you can be able to fill your post-session polls so we can see how impactful this session has been. We appreciate you, and yes, and we'll give opportunity for any one or two comments. One or two comments, Dr. Mary, from your side.
I think it's been a wonderful session. I've learned so much myself.
You can go ahead.
It's been a wonderful session. I've learned a great deal myself, and I think one of the things that I thought of when Dr. Darius was giving us his results is that I think sometimes with those emergencies that we don't always manage as well, we often do the right thing the first time, but we forget that none of those diseases, none of those conditions are one-time treatments. If you have hypotension, it's not something we treat once and walk away. The patient has hyperkalemia, you don't treat it once and walk away. These are conditions that require you do something, you monitor it, you probably need to do it again. And I think that was a good reminder of that from Dr. Darius.
Thank you. I think those are a very good point, Dr. Mary Ellen. And like Dr. Owachi said, there are particular conditions that are really poorly managed, and yet they are the most common of the emergencies that we tend to see in our emergency rooms. So I think everyone from this talk should be able to take note of those particular three conditions, but not to say that you forget about the rest, but pay attention to those that have particularly been highlighted so that you not miss them out, because they could potentially be lethal, and you need to intervene as timely because it's a matter of time. Isaac, what has your experience been? Any feedback about the session?
Thank you very much. I'm very humbled to have been invited to give this talk. I would gladly come back. Very intriguing questions in the chat, very intriguing questions, and this topic is so broad. And since we've discovered this pandemic, we've been learning and learning and learning, and we are going to continue learning. I think that's the highlight for me. Thank you.
Thank you, Isaac, and thank you for that very comprehensive session that you gave. I think I really liked every single bit. of the session that
Hello.
Yes, we're going to get back to you in a minute. Let's just get feedback from the panelists. Yes, Liberty.
Yes, thank you so much. I'm really grateful for having presented the case, and I think as a doctor who is coming into practice, I've learned a lot. And I think as I enter into the world of practice, the way I handle clients with HIV would really be greatly different. Thank you so much for giving me the opportunity to be in this session.
Thank you, Liberty, for the case. I think it's been a wonderful case, quite fitting for our discussion today. And we really thank you for being straight to the point and having it precise. Diana, how's the experience been? Thanks for the nursing care. That makes a big difference.
Okay, thank you so much. I've also learned a lot. But one thing to take home is most of these patients that come in with HIV, especially the newly diagnosed, come in very sick. So therefore, it enables us to understand that we have to give them the best care so that we improve their prognosis. Because we're still facing a high mortality, a high HIV mortality, but hope with this education, we shall be able to improve and reduce the mortality as a team.
Thank you, Diana. I'm going to give the floor now to, all right. I must say that it's been quite an impactful session, both to the panelists, just like you have had their feedbacks. Everyone has take-home messages from this talk, and I'm very sure that the audience as well have been able to pick quite a lot. That's going to change our approach to patients with HIV, that we are not just looking at HIV, but we also try to seek for potentially life-threatening conditions that they might be presenting with in our ED every day. We get to see them. So I must thank the team that picked the topic. It's quite timely. And I know that we're beginning the year on high gear and we are going to save more patients. Thank you too also for filling the polls. We thank you all for attending. Thank you. Goodbye.